Friday afternoon, a little bit later than normal, but had a little technical difficulties earlier. Got it all straight, I think. Looks like we're back up to speed. So if you're jumping on, if you hear me and see me, let me know. So we'll know if this thing's working or not. Appears to be working on my end, but I can't really tell. So hey, people are jumping on YouTube. Hey, all right, cool. So it's Friday afternoon. Folks are jumping on YouTube. We'll see if anybody jumps on Facebook. Just doing a little live Ask Me Anything video again. Got a new video up coming pretty soon talking about air quality. I mentioned this last week, and I finally got able to take a look at the actual data from the study. It was published in this journal called Fertility and Sterility by the University of Utah. And what they found was that there was a substantial increased risk of miscarriage in the days that followed worsening of air quality. So for every 10 parts per billion of increased nitric dioxide in the air, it turned out the rate of miscarriage went up about 16%. So it's not proof, of course, but it certainly is suspicious and definitely adds to the additional, adds to sort of a growing body of evidence that air quality definitely has risks associated with adverse pregnancy outcomes. So previous studies have looked at the risk for autism, stillbirth, growth restriction, things like that. Well, now we also can add miscarriage to that list of potential issues. So again, today is a bad day. If you're here in Utah, if you're out in the valley, you will see some pretty nasty air. And I might just jump on the web here and see what the current levels are. But it looks pretty gross. So let's just see Utah air quality. Let's see what it is right now. I think it was yellow earlier, but we'll see what kind of numbers we've got. Current conditions, here we go. Hey, from Australia, holy cow. Amber, wow, that's amazing. You probably automatically win the where is anybody coming from today. So welcome. If you have a question, put it in the comments. Yeah, let's see. PM 2.5 is up to 47.3, so we're up to orange currently in Salt Lake and in Weber County. And from Toronto, well, we got some people coming off from ways away. So let's see, got some questions popping in here. Let's see, how many IUIs on average does it take to get pregnant for 35 going on 36? So, you know, there's no good numbers that I can tell you like per year, like I'm 35 or I'm 34 or I'm 37 or whatever. We just know that, oh, sorry, IUI is intrauterine insemination. Laura Bell. I think you know Laura Bell. Is this Laura Bell that I know from somewhere in North Carolina in the past, or is that just a strange coincidence? But anyway, IUIs, intrauterine insemination. So we do this for a number of reasons. And, you know, we can kind of get into those as we go. But, you know, anyway, the question was like, what's the percent chance? So I would just kind of quote generic. Amber says, can't hear you good. Let me turn up my microphone. Amber, let me know if that sounds better. I just turned up the mic. So guys, let me know they're on Facebook if it's getting better. 10 to 15% per cycle is a reasonable, just round number kind of guess for conception rates with whether that's spontaneous or intrauterine inseminations. So I'm just gonna, much better. Okay, thanks, Hillary, thank you. I just need to turn up the microphone. So thanks for letting me know, guys. If you have questions, pop them in there and we'll get talking. Let's see, saw some other questions here. Kimberly, having cramps on and off all day, not painful, just Braxton-Hicks maybe. Yeah, probably. So, strange coincidence, that's funny. Sort of what I tell people when, just with pregnancy in general, if you're having contractions, if they are just random, not terribly uncomfortable, then probably nothing to worry about. My general recommendations are if you feel contractions coming and going like every 5 minutes for an hour, I'd head in and get checked out because maybe it's a possibility that labor is underway. But if they're less frequent than that, then I don't worry about it. All right, cool. Let's see. So everybody's saying much better on the volume on Facebook. Thanks for letting me know, guys. If you have questions, just jump in there on the chat and we'll get to work here. Let's see. Let's see here. Amber, Delivery Baby March, love listening. It's very nice to save you. Always miss it because of the time difference. Yeah, so what time is it in Australia currently? Holy cow, it must be like 4 in the morning or something like that. I have no idea. It's way out there somewhere. So what time is it in Australia? Let us know. Let's see. 28 weeks pregnant, don't have much appetite. 9 a.m. Wow. Okay, so that is ways ahead. Let's see. I'm just gonna mute this. There we go. 28 weeks pregnant, not much appetite is a question. Fairly common complaint. And I think that it's probably a combination of factors. Number one is you do have a rapidly enlarging pelvic and abdominal mass known as your uterus. And it does kind of push on your stomach. And that, it's kind of like just being compressed. And so your stomach feels kind of full, I think. So I think that's probably part of it. There may be some other hormonal stuff going on. Your GI transit time does slow quite a bit when you're pregnant. So in other words, the amount of time it takes for food to get from one end to the other is longer when you're pregnant than when you're not. And that may also contribute to just a reduced appetite. So sounds like pretty normal stuff. I would just kind of focus on making sure you're staying hydrated, small frequent snacks. And as long as you're gaining healthy weight and the baby's growing good, then ultimately probably gonna be fine. Let's see, Jordan says, is there a better time of the month to come in to discuss fertility treatments? I'm assuming you mean like based on your cycle. So for the initial discussion, doesn't really matter. Just probably best bet's just make an appointment and we'll talk about it in the office. In general, we start talking about fertility treatments. Most things start around cycle day 3. So whether that's Clement or Femera, those are the ones that we do in the office. Those are usually kind of a day 3 start. So if you're coming in, before your next period, then we can kind of plan on starting things around day 3. There is a video on my YouTube channel that talks about that, and just in terms of how I recommend you take Clomid or Femera. So if you haven't seen that yet, maybe jump on my YouTube channel and check it out. Yeah, thanks. My dogs are kind of wandering around the background. You can't really see them on YouTube, but there they are in the corner. I had that over there. So yeah, I've got an old golden retriever and a little corgi who's not quite a year old. Or I guess he's just a year old now. Let's see, Amber, 27 weeks, I've only gained about 4 kilos, so about 8 pounds for those in the US. And people say you're on the smaller side. What does that mean? So, this is like I spend a lot of my day kind of answering these kind of questions. And from Italy, wow, it's amazing. Good to see you again. Pregnancy-associated weight gain. So, if you gain about 15 pounds for the total pregnancy, you've gained what is essentially the bare minimum. So if you're, 2/3 the way there and you've gained about 8 pounds, you've got a little extra weight to gain maybe. But in and of itself, not typically a huge deal if you're not malnourished to start with. So if you have otherwise good nutrition, then, it's certainly not unreasonable to get an ultrasound just to check the baby's growth. And assuming the baby's growing good, then ultimately probably not anything to worry about. But what I was getting at was a lot of people come in and they say, my mom said this, or I said I looked too big, or someone said I looked too small. So I spend a lot of time talking to people about that kind of stuff, and my basic advice is don't talk to people. Let's see, Jordan. OB said can't take Clomid, we'll need IUI time of month is what you meant. Yeah, I don't know, I'd say just maybe make an appointment to come on in and we'll talk about it, kind of go from there. Cool, all right. We'll see if there's other questions popping up here. Europe too, east of Europe. Kosovo, yeah, I've heard of Kosovo. Holy cow, that is amazing. We are like super international on YouTube today. That's amazing, guys. Thanks for jumping on. That's crazy. I've not been to Kosovo. I have been to Italy. I have not been to Australia, but I have been to New Zealand. I know they're not the same thing, but that's as close as I have come so far. We'd like to go to Australia someday. Kosovo's up there too. I mean, I don't know much about that particular area. I have been to Croatia. I don't know exactly how far away that is, but I think they're not too far away from each other. Let's see, Tiffany, what causes leg cramps when stretching during pregnancy? And what can you do to make it stop? Super common question. Get this one a lot. I think, one answer is that most pregnant people tend to run a little low on their serum potassium levels. So if you draw the blood levels of a pregnant person, potassium is virtually always low. And it's actually low enough that if someone who's not used to taking care of pregnant people sees it, they will freak out. So long story short is that potassium can be low. So sometimes just increasing dietary potassium really does help. And bananas, as Jordan just laid, looks like a little banana emoji on there. Bananas are a good source of potassium. Orange juice is another one. Apparently spinach has good potassium as well. So if you like spinach smoothies, do a banana and a spinach and throw some, maybe some kale or something else in there to make it taste better, and you've got yourself a pretty good smoothie. It might help with your leg cramps. If that doesn't work at all, then another option is to try a little supplemental magnesium. So I wouldn't recommend taking large doses, but if you just get it like at the pharmacy and just take sort of a normal dose, and I don't know the dose off the top of my head, but you could ask the pharmacist. A low dose magnesium supplement sometimes also helps. So that's something else to consider if the potassium trick doesn't help. Now, I don't recommend taking a potassium supplement. Those really, you shouldn't be able to get those, but if you were able to get your hands on one, don't take it. You can actually overdose potassium pretty easily. And so if we give someone supplemental potassium, we have to monitor the blood levels very closely. Now, you can't overdose on bananas, so don't worry about it that way. But if you took just a pure potassium supplement, it could be an issue. So just stick to dietary sources on that one. Let's see. Tia is 11 months postpartum and breastfeeding, having some cramps, lasts for a couple of days, never happened before. Yeah, hard to know. I mean, it could be ovulation. It could be a baby that's finally going to start. It's hard to know. I mean, basically, I kind of sort of say wait and see what happens. If the pain becomes severe, then always certainly real reasonable is to come in the office, get checked out, be an ovarian cyst or something like that. Hard to speculate just based on the little bit of information that we have there. But those would be the kind of things that would just sort of, run through my head is based on the information I have. Okay, let's see. Amber, baby says baby measures fine, sits more towards the back. What is that? That won't show as much as possible. I think everybody's body type is just so different. People's torso lengths are different and body mass indexes are different. So just a whole lot of reasons why baby may show or not show or whatever. But as long as baby's growing good, then you got nothing to worry about. Okay, let's see if there's other questions popping up. Choke down some bananas. Baby hates OJ. Yeah, orange juice definitely can like make your reflux worse for sure. Let's see. Well, I think I'm all caught up. That's crazy. So hey, as you guys are, here's one. Took one round of Clomid last period in a week. If it didn't come, oh well, good luck indeed. Hopefully that works out for you. Let's see. I think I'm caught up on both channels here. Okay, guys, I need more questions. Put some questions in the chat. I got nothing smart to say right now. So far, nothing. Oh, I was talking about this this air quality business, and I was just getting into that when some questions started popping up. So, yeah, we are in a yellow right now, which it's kind of a broad range, but definitely potentially risky. So if you're pregnant, stay indoors. Or if you have to be outside for a long period of time, maybe consider wearing one of those N95 respirators. And that's just based on, again, recent study that showed a higher risk of miscarriage in moms who were exposed to this worse air quality. So just keep it in mind. Let's see. General people here get an ultrasound every month, every visit. So how do I recommend that? So as a doctor, yeah, I'm sorry. I'm sort of. I guess maybe one question in this question here is just what are the risks of ultrasound? Let's say in pregnancy, and the short answer is in normal use. I think it's virtually risk-free. It's not any major exposure. Now, if you sat there with an ultrasound probe on a baby for a long period of time and use like power Doppler or something, that could be an issue. But I think in normal use, it's not a problem and not anything that we worry about. Let's see. All right, Bethany's making fun of me over here. How's it going, Bethany? Let's see. 28 years old, want to get pregnant. Husband is always between 10 and 11, hemoglobin. I thought that was like husband. Take iron tablets, irregular periods. Does this mean any problem? No, so there's really no evidence that I'm aware of that sort of mild iron deficiency could impair fertility. So I don't think it's anything to worry about. It's interesting, if you're taking iron and your hemoglobin is still kind of low, do you have some other underlying hemoglobin abnormality? So that's something to think about. If you haven't had a hemoglobin electrophoresis yet, then that would certainly be something to check on. So there's thalassemias, there's sickle cell, there's a few that can cause different types of anemia. So if it's not iron deficiency, it might be something else. So just keep that in mind. Let's see, Tia said cholestasis with the last pregnancy, what are the chances of having it again? It's definitely a higher risk. The number escapes me just off the top of my head, but if I had to throw out a guess, I'd say it's somewhere in the 15 to 20% recurrence risk. It's definitely much higher than the background population risk, which is supposedly like 1 in 1,000 pregnancies. So it's definitely a lot higher if you've had a history in the past than if you never have had a history. So it's something to watch. And I mean, the good news is if you know about it, you can detect it, you can treat it, you can monitor for it. And generally speaking, the outcomes are good. I've personally, never had any problems from that. We just generally deliver around 36, 37 weeks. We monitor very closely in the third trimester. And so far so good as far as my experience goes with that. Let's see, is it normal, Amber, is it normal for cramping to get worse with PCOS right before you start a period? Past 4 months get more painful? Not necessarily. So, PCOS is one of these, polycystic ovarian syndrome. It sounds like you ought to have ovarian cysts because it's right there in the name. But as it turns out, really you don't, not typically. And so, there's really no increased risk of ovarian cyst formation with PCOS. It's kind of a bad name. So at least as far as that goes, I wouldn't think that would be an increased risk for pain. And in and of itself, I wouldn't think that periods are any worse with PCOS when you do have a period versus somebody who doesn't. So I don't necessarily know that it has anything to do with it. It may be something else going on. It seems like it's been more painful over the last few months. So maybe something has changed otherwise in your health, and maybe that's why it's more painful. So it might be just getting things checked out, getting an exam, ultrasound, things of that nature, and see what's going on. All right, let's see. Okay, Amber, I've seen some women deliver after 24 weeks. Why would that be? Or someone's water breaking around this time? I guess sort of one question in there is like, what are the causes of preterm birth? And what are the causes of like preterm premature rupture of brains? And the short answer is it's a mystery. It's one of those things that a lot of research is being done trying to look into the causes of preterm birth. A lot of the theories revolve around this theory of inflammation, that there's some kind of maybe low-grade infection going on that has led to inflammation. Inflammation causes weakening of the membranes, weakening of collagen fibers within the cervix maybe, that somehow sort of causes a cascade of events that ultimately leads to labor or ultimately leads to your water breaking. Although the honest answer ultimately right now is we don't know, but it is definitely an area of active research. And if someone ever figures out what the cause is, which is probably more than one cause, but if someone ever finds out a major cause that's preventable, that'll be like Nobel Prize in medicine kind of research. So fingers crossed that someday we'll learn something about that. Let's see, Jenny, 6 weeks pregnant, got the flu. Ooh, bummer. Sorry to hear that. Haven't been able to keep your vitamin down for a couple days. Baby be okay. Oh yeah, so I wouldn't worry about your prenatal vitamin. I'd be more concerned about if you're unable to keep down liquids. So if you can't keep down liquids for more than 24 hours, my advice is always get some IV fluids. So either go to urgent care or emergency room or whatever nearby and get tanked up with some fluids, because what you don't want to get is just bad dehydrated. So if that's the case, that'd be my advice. Now the other thing is that if it's definitely the flu, now some people get nausea and vomiting, the stomach stuff, and I mean it could be the flu, but it doesn't mean that it is. But if it's a high suspicion for the flu, then in pregnancy we have a very low threshold for treating that with Tamiflu, just because the risks of complications from influenza are more severe in pregnancy than in the non-pregnant state. So just keep that in mind as well. But if things aren't getting better, my advice is go get checked out. Fluids are okay for the most part, good. Okay, so it's just your vitamin, in which case, yeah, don't worry about that. Okay, let's see. Tiffany says, 37 weeks pregnant, no dilation yet. First pregnancy, already 2 centimeters at 35. Do you tend to dilate later in a subsequent pregnancy? The short answer is they're all different. In general, I think you may see that people tend to dilate more sooner in a subsequent pregnancy than in a first pregnancy. But at the end of the day, the truth is they are all different, and you just never know. So good luck. Hopefully things wrap up for you soon, but it doesn't mean much about when labor may or may not start. Let's see, Laura says, started to conceive December, having a light period, several days early. Almost thought you were pregnant. I mean, it's possible. So, like implantation bleeding could be a thing. So keep that in mind. If you don't have a real period in a day or two, then check a pregnancy test if you haven't already. It's possible. Aside from that, I don't think it means much. Let's see. I mean, I haven't checked since I'm having my period, but found it bizarre. Oh yeah, I'd do a pregnancy test, Laura, for sure, because I've seen this a few times where someone has kind of a weird period, maybe it was a little bit early, it was light or whatever, and the thought was, well, that's my period. Well, in reality, that's implantation bleeding or bleeding from early pregnancy. So I'd check a pregnancy test. You never know. Jenny, yeah, diagnosed with flu A and on Tamiflu. Well, I'm glad you're on meds. As long as you're keeping your fluids, then you and the baby should be fine. So hopefully you get better soon. And that's definitely a plug for anybody who hasn't gotten a flu shot yet. We still have flu shots at the office. If you haven't gotten one, go get one. They're closing in 49 minutes for the day, but come get one Monday. We still have plenty, and that's whether you're pregnant or not. And hey, Kayla, how's it going? Are you working tomorrow? I was up there today, and it was nice. It was nice at Snow Basin. It was sunny and pretty nice groomers. So we're hoping for some snow maybe this weekend, get some powder. Let's see. Zahar says, any prenatal vitamins recommend safe from start conceiving? Really, any prenatal vitamin is fine. The only most important thing is that you have an adequate amount of folic acid, so about 400 micrograms per day, and more is better. More is certainly not harmful, but at least 400 micrograms of folic acid. That's going to reduce the risk of spina bifida in babies because that's mostly due to folate deficiency, although that's less true lately, at least in the U.S. because the grains are fortified with folate. But that's still a good idea. And then a little bit of vitamin D is not bad. There's not tons of vitamin D in most prenatals, so I'd look for about 1,500 international units of vitamin D as a supplement and take that as well. There are some studies that show lower rates of miscarriage and better fertility rates in moms who have therapeutic levels of vitamin D. So I've been talking to folks about that more lately. Kayla, worked all day, being the dispatch begin tomorrow. Well, maybe if you're there Sunday, I'll look for you. We didn't go up to John Paul today. It was just kind of windy, and we made a few runs on the groomers and just cut out of there, but it was a pretty day. Let's see. Elise, PCOS, endometriosis, had surgery kind of not too long ago, trying to get pregnant for about 18 months, pretty regular cycles, started on metformin. How long should you take it before something else? It's a good question. I mean, you didn't say, so, but if your partner's semen analysis is normal or not, but assuming that it is, then, and if you don't know, then get it checked, because if we don't know, we don't know. But if the semen analysis is normal, and it's been 1.5 years since your surgery, and you're only on metformin, I would be trying some Clomid, maybe for a few cycles, or Femara, which is letrozole. And if you're not getting pregnant, within 3 to 6 cycles of Clomid and Femara, and plus or minus inseminations, depending on what the semen analysis looks like, then it may be time to start thinking about more aggressive fertility treatments in general. So endometriosis is one of these things that, even when treated surgically, it doesn't always improve your fertility. So sometimes you do have to go to more aggressive treatments like in vitro if these other things won't work. So best of luck, hopefully it does. But I would maybe think about adding in some Clomid or Femara now, and then plus or minus on inseminations depending on semen analysis results. And if that hadn't been done, I would do it. Cool, good question. All right, let's see. Patricia, dilated 2 centimeters, 24-hour, period reduced, I get C-section. Anything you can do naturally? Not really. About the only thing that, you didn't say why you were induced, but if you don't mind putting that there, I'm just curious. If it was not a sort of medical emergency, you got to get the baby out kind of deal, then one answer is just wait longer. So, one thing that we have definitely learned is that labor takes longer than we thought it did, and that being patient often really helps. And even going beyond 24 hours might be necessary. So, excuse me, I would just keep that in mind for the features induced because of GBS. Water had gone slowly, like a slow leak, maybe you're thinking, maybe that's what you're saying. So yeah, it definitely sounds like induction was appropriate. So about the only thing I'd say is that with the subsequent labor, if you're trying for labor after C-section, then just being patient, just giving it time, and as long as baby's okay, and as long as you're doing okay, waiting it out. Most people will eventually get into labor, if given enough time. And part of the problem in the past, I think, has been, as providers, we're just not patient enough. And that's one thing I've learned over the years is being patient pays off. I have a much lower C-section rate as a direct result of just waiting. So I just keep that in mind. Let's see, Jenny, reconstructive hip surgery 8 months ago, hoping for a VBAC. Yeah, I don't think there's anything to the hip per se that would preclude you from trying for labor unless your doctor who did your hip surgery says you can't. But I wouldn't think that it would matter. You may not be able to do a lot of real hard hip flexion if you've had hip surgery. But even so, I mean, we should be reasonable to modify your birth position in a way that sort of allows for your hip to be happy and still allows for you to try for vaginal delivery. So I don't personally, just from what you've told me so far, think that's a deal breaker. So I would definitely think that it's okay to consider, but maybe run it by the person who did your surgery, but I wouldn't think it'd be a problem. Okay, let's see. Caitlin, what is the likely chance of vaginal cancer after hysterectomy due to cervical cancer? Let's see. Pap came back, abnormal squamous cells. Yeah, I mean, there is some residual risk of like vulvar cancer or vaginal cancer, like at the vaginal cuff. But if the pap wasn't showing anything concerning for cancer, then a more conservative approach certainly seems normal. Hard to give you a number. I'm not a GYN cancer specialist. I'm a general OBGYN. We definitely do pap smears and all that stuff. But once you start talking about cervical cancer, if it's your oncologist who's saying, we're just going to watch this, and I would definitely, defer to their judgment. Let's see. 28 years old, high risk of having gestational diabetes. Are you high risk? Okay, or high blood pressure, people, what is that? Right. People here say you can't have more, you can't have that if you're not older than 33. No, I mean, anybody can develop. So age definitely is a risk factor for things like gestational diabetes and preeclampsia and things of that nature. But it's certainly entirely possible for anyone of any age to develop those things. So it's not a you can't. Maybe you're a little bit less risk based on age. There are other risk factors, of course, specifically for things like preeclampsia. There's things like, do you have a history of chronic hypertension? Because that's a risk factor. Twins are a risk factor. Being overweight is a risk factor. Chronic kidney disease is a risk factor. So a lot of things that play into that besides just age. So I wouldn't say, no, you can't have them. Body mass index is a big predictor of gestational diabetes and hypertensive disorders. So if you're overweight, that means you're a little bit higher risk. So it's kind of hard to answer based on what the question about the info you gave me, but hopefully that's helpful. Oh, hey, Angela just jumped on. I don't know if some of y'all probably know. Angela is my medical assistant. She's my work wife. We've been working together for like, what is it, Angela? 10 years now almost. It's crazy. She's the person who keeps me straight in the office and keeps me on track. So let's see. Tiffany, nipple stimulation with a breast pump around 39 weeks could help induce labor. It's not going to hurt anything, but will it actually put you into labor? Probably not. We used to do nipple stimulation contraction stress tests. So we were trying to monitor a baby on the non-stress test machine, and 10 years in August, that's what I was thinking. And so you could do it with nipple stimulation, but I never saw anybody go into labor. So I really don't think that it's that big of a risk, or in your case, that big of a help, because you're probably looking to make it go into labor. So yeah, Angela, 10 years, pretty crazy. All right. I think I'm all caught up, you guys. I need some more questions, please, because I've run out of things to say. Oh wait, I missed one. Have I personally ever seen, heard of patients have any complications, side effects, post labor from having the epidural? Not really. I mean, it's so post epidural mild low back pain I think is fairly common. Now it's hard to know if it's just a pregnancy thing or is it an epidural thing or is it both. I don't know of any good evidence, like I haven't seen any good research that would really answer the question, but I will say that it's fairly common for folks to say they've had a little mild low back pain after having an epidural, but it's always temporary, it always goes away. I would personally never let that stop me from getting an epidural if I was having a baby. I'd have an epidural every time. Let's see. Tiffany says, does the risk of multiples go up even more with age and fertility treatments? 33, had to do Femera for your last baby. So age is a risk factor, but typically beyond 33. So like high 30s, early 40s is where you see a substantial increased risk of twinning. There may be some slight increased risk at 33, but it's not a huge risk. Probably the dominant risk in that situation would be if you were taking Clomid or Femera. There's about a 5% risk of twins in with those medications. So probably age doesn't add much to it. Let's see. Jenny had a rough pregnancy with the first one. What's likely of having another rough pregnancy? Kind of vague. Not really sure what that means. If you tell me specifically what was going on, I might be able to answer it a little better. But hard to know from information that you gave me. Let's see. Something popped up over here on YouTube. What was it? Is age a factor with men for having twins? No, it turns out that it's not. There's something about egg quality declining as you age that nature somehow tries to work out by releasing more than one egg. So you have more chances of dizygotic twins, so more than one egg getting fertilized. And it's probably just nature going, gotta get some more eggs out there, so hopefully one of them will fertilize, because as egg quality declines, chances of pregnancy go down. So I think that's kind of nature's way to improve your chances of pregnancy is, well, let's let more than one egg go. And so I think the chances are that, higher in that case, that, well, more than one might fertilize, and therefore risk of twins is a little higher. All right. I think I'm caught up again. Sorry, oh, by the way, sorry I was late today on this thing because a piece of my streaming equipment and I had to run to Best Buy and pick up a replacement part. But we're back on the stream, thank goodness. Let's see. Zara says take Paxil, put you on Lexapro, got some anxiety, say stop, try and take back off Paxil, proceed. Yeah, so I mean, there's really no evidence that Lexapro is any better than Paxil. And there's really not good evidence that Paxil or Prozac or Zoloft or any of those first generation SSRIs pose any kind of major risk of birth defects. There were a couple of reports, gosh, probably, well, I know more than 10 years ago, that said, maybe some slight increased risk of certain heart or brain defects. I forget what it was now, but they were so rare that even with the increased risk, they were still very rare. And so even if you believe that maybe there is an increased risk, it's still so low. And I think that the risk of untreated depression and anxiety far outweighs any theoretical risk there might be from those type of medications causing birth defects. And I think that is generally the consensus of most OBGYNs and maternal medicine type people, that really the risks of untreated depression are far higher than any theoretical risk there might be from these SSRIs. And I made a video about that actually on my YouTube channel, so you can check it out. Hey Desiree, what's up? When should you stop traveling internationally during pregnancy? That's a good question. So a couple ways to think about that. One is there's always some risk of preterm birth, and even when you don't have any personal history of that, it could still happen, I suppose. And then you think, well, what's the likelihood of that happening at an age? And then you think about what's the gestational age where babies are potentially viable. So somewhere in that 23 to 28 week neighborhood is where there is a risk for preterm birth, and those are babies that are definitely viable, or 23 weeks you say is potentially viable. What's the likelihood something like that happens and you're overseas? It's very low when you have no personal history of preterm birth. That's different if someone had a history of preterm birth. It's a whole different story. But if it was me, if it was my wife, you know, somewhere in that neighborhood, I'd probably stick to the continental U.S. Now, I think perfectly reasonable to travel all over the U.S. at that point still. And so if we talk about domestic travel, I usually say like 34, 35 weeks, just because, hey, you never know, your water might break, you might go into labor. And in those situations, well, you want to be at home at least when that happens, so your baby's not in a NICU somewhere halfway across the country. But if it was me for international, I would probably shut it down somewhere in that 23 to 28 week neighborhood, just because you do have a viable pregnancy at that point, and you know, who knows where you are, what's the healthcare system like, and furthermore, you're a long way from home at that point if you get stuck there. So, long-winded way of saying 23 to 28 weeks, somewhere in that neighborhood. Let's see, Jenny, kidney stones and early labor, but not dilating. Okay, so yeah, kidney stones are definitely one of those things. If you have a history of kidney stones, there's a chance your kidney stones will be back, and those are a bummer. There's something about pregnancy that increases the risk of kidney stone formation. It probably has to do with the fact that when you're pregnant, you're what is known as a hyperfiltrator. So your blood is going through your kidneys at a much more frequent or a much higher volume than when you're not pregnant. And so whatever stuff is in the blood that's ultimately turning into a stone in the kidney, there's just more of it going around. So there definitely is a chance of that. And then early labor but not dilating. I guess if that's not preterm birth, I'm not too worried about that. But the kidney stone thing, it definitely could be an issue. You know, maybe getting that checked out before you get pregnant, just to see kind of what the state of your kidneys are. Are there stones in there? Not that it necessarily is going to make you not have a kid, but maybe at least you know kind of what you're getting into. And if it turned out that you had a big kidney stone, that if that was diagnosed before you got pregnant, that could maybe be treated, and that way wouldn't flare up while you're pregnant. So that's maybe something to think about. All right. Let's see. Can Clomid cause twins? Yeah, so about a 5% risk of twins with Clomid. So definitely can happen. Not a huge risk. Let's see. All right. Christy, back in Utah, just had double mastectomy. How soon should you come in and have a checkup? It's a good question. I don't know where you had your surgery, but I mean, typically, the surgeon who did the surgery is going to tell you when you should have follow-up for that, and so I don't think there's anything specific to that for me. But the other question, of course, is, well, most people who've had, say, prophylactic mastectomy have had that because they have some family history of breast cancer, and maybe some have identified with one of these breast cancer genes. The BRCA1, BRCA2 are kind of the typical examples, but there's others. Some of these genes also confer an increased risk of ovarian cancer. And so if the story goes like this: family history of breast cancer, or personal history of breast cancer for that matter, diagnosed with a BRCA1 or a BRCA2 mutation, we know that those people are also at higher risk for ovarian cancer. And so one surgery that is very commonly recommended is to perform removal of the tubes and ovaries, or that's called a bilateral salpingo-oophorectomy, or BSO. Recommended BSO after completion of childbearing, because their risk of ovarian cancer is potentially in the neighborhood of 40 or so percent. And so once you're done having kids, that's something to think about, and that would definitely be a reason to come in and talk about, is to see where you stand on childbearing status, and see where you stand as far as thoughts for future fertility and all that kind of jazz. So it's maybe worth coming in just to talk about that, and maybe just following up with your breast surgeon based on whatever kind of follow-up they recommended you have, and then kind of go from there. Let's see, Samantha, is it normal to lose your mucus plug, Pranksy, Braxton-Hicks, 20 weeks? Yeah, so the whole mucus plug thing, it's probably not as big of a thing as people believe that it is. But what I mean by that, I mean, hardly ever do you hear somebody like, I asked my mucus plug and then I had a baby. I mean, it happens, but it's actually not that frequent. The pregnant cervix is more just like a runny nose. It makes a lot of mucus, and so you may just have a lot of mucus you discharge the whole pregnancy, and I think that is by far and away much more common than someone who passed a mucus plug. So that's not so concerning. 20 weeks and painful Braxton-Hicks, as long as they're irregular, not frequent. So I kind of tell everybody the same thing about this as far as contractions go. If they're coming and going every 5 minutes for an hour and they kind of hurt, you ought to go to the hospital and get checked to make sure it's not labor. If they're less frequent, if they're not painful, if they go away when you rest, then I don't think there's anything to worry about. And that's just what I tell everybody when it comes to labor type symptoms. So hopefully that answers your question. Let's see. Are there any symptoms related to gestational diabetes? No, and that's why we test everybody. So there really are no specific symptoms of gestational diabetes that you can rely on to say, well, I didn't have those, so I don't have diabetes. There are symptoms that are fairly common in diabetes: frequent urination and thirst. Well, guess what? That's what most pregnant people are, thirsty and peeing a lot. So hard to do it based off of that. So that's why we test everybody. So everyone should get screened, and that's the best way to pick up on as many cases of gestational diabetes as possible and hopefully improve outcomes for those pregnancies. So that's why I just say get tested. Let's see, Christy, DCIS, okay, fluky thing. Genetic testing came back negative. They said after reconstruction get pregnant. Great, well that is good news. So yeah, just a regular checkup soon sounds really good. That's great news. I'm glad that it wasn't anything worse than that. So yeah, just come see me. We'll talk about getting pregnant. That sounds great. Let's see. Tina just learned they're pregnant. Congratulations. 6 weeks today. A lot of symptoms. Is that normal? Yeah. So, you know, not everybody feels terrible when they're pregnant. Now, a lot of people have some kind of symptoms, but there's definitely people out there who just feel fine. And so as long as you're not having any bleeding, you're not having any severe pain or anything, then just be glad you don't feel bad so far, and fingers crossed that it stays that way. Let's see, Kara had a baby 3 months ago, calcification in her right kidney. Could that be from giving birth? Well, it could be from being pregnant. I was kind of talking about that a minute ago with Jenny, who's mentioned history of kidney stones. And so, you know, I think pregnancy is a time when you see more kidney stones popping up. And again, I think that might be because pregnant people, filter a lot of blood through their kidneys and make a lot of urine. So you're hyperfiltrating. And if you're a hyperfiltrator and you're prone to forming kidney stones, it's kind of a setup. So that might be what you're talking about. It wouldn't necessarily be from having a baby per se, but just from being pregnant. All right. I think I'm all caught up again. Okay, guys, hit me with a few more questions, and we'll see what everybody else has to say, and maybe keep going here for another 10 or 15 minutes if we keep getting questions, and then we'll call it a day. Okay, see some new folks popping on YouTube. So if you're just jumping on, welcome. It's Friday, Facebook Friday, late today, thanks to some technical difficulties that it took me a minute to get worked out. But if you have questions, put them in the chat and I'll be happy to answer them. Let's see, got some questions here. Try not to worry, just being scared. Yeah, absolutely, it's understandable. And you definitely know of people who've had miscarriages who definitely feel better when they're nauseous. Like, I feel terrible, I know I'm pregnant. So I can definitely really understand that. But hopefully you're just good and not feeling bad. All right. Looks like I'm still caught up. So if you have questions, put them in the chat. And if for some reason I didn't answer your question, it's because I didn't see it. Sometimes they just don't pop up in the feed. So if I missed your question, just copy and paste it back in the chat and maybe it'll pop up this time. But I think I'm otherwise all caught up here. Looks like it. All right. We'll give you guys a couple minutes, see if any more questions pop up. So far, nothing. I always say, like, ask me a question, because otherwise I just sit here and look dumb. I'll jump on YouTube for a minute and just see if there's any interesting questions from lately that are kind of good for everybody. Let's see. I'll just jump in the comments here. Let's see. I can't get to my YouTube channel for some reason. All right. Well, no questions. Okay, we'll give it a couple more minutes and see if anybody has a question to ask. I see some folks, new folks jumping on YouTube, so welcome if you just jumped on. If this is your first time seeing me, hey there, Wes Davis. I'm going to be in Ogden, Utah, and this is my Friday afternoon hobby is to jump on live stream and answer random questions, mostly having to do with women's health. So if you have anything along those lines, throw it in the comments. Let's see. Here's a couple popping on Facebook. Let's see, Kara. Got the depot shot, a lot of side effects like hot flashes, weight gain, muscle cramps, whatnot. Should you switch, and how well does the birth control patch work? So weight gain is a fairly common side effect from depot Pervera, that's a fact. Hot flashes, you wouldn't think so much because it's progesterone, so it shouldn't aggravate hot flashes. Muscle cramps, hard to say, but the weight gain for sure. Should you switch? I guess it just kind of depends on how bad those things bother you. And then the question is, what about the birth control patch? It's, it's fine. It has kind of fallen out of favor only because it's a bit higher dose of estrogen that you get from that patch than say from a typical birth control pill. And so the concern is, maybe a little higher risk of blood clots and strokes and things of that nature. Now, I will still prescribe it to someone if they've used it in the past and said, I did fine, took it for years, no problem, want to keep going. I think that's great, but I'd be a little hesitant like on a new start. So I would just explain that to the person and just say, understand that there might be a little higher risk of these kind of complications compared to say just your typical birth control pill. As far as like effectiveness goes, it is just as effective as any other method. If used correctly, definitely up in that, 99 point something %. Let's see. Samantha, how accurate is non-invasive genetic testing? Marker found on your anatomy scan, but don't want to worry unnecessarily. Yeah, so the non-invasive genetic testing, so for example, the cell-free DNA, that's kind of where everybody's going these days, is very accurate for 4 things. So it'll give you DNA level certainty for Down syndrome, trisomy 13, trisomy 18, and sex chromosome abnormalities, and that's it. So those are 4 of the most common abnormalities that you'll pick up, but they're definitely not all the abnormalities. Now, a single marker on an anatomy scan, if everything else was normal, only increases the risk very slightly. So it's not a big thing to worry about necessarily, but it's certainly not wrong to say, well, we did find a marker, let's do this test. And the nice thing about it is non-invasive. It's a pretty quick turnaround. You get results in about 7 to 10 days. And it is DNA, so you can rely on it. Nothing is going to be 100%, of course, but it's about as good as you can get without doing something invasive like an amniocentesis. So certainly very reasonable. Let's see, Brooklyn, what hospitals? So I deliver at McKay D Hospital and Ogden Regional, both in Ogden, Utah. Okay, Reina's question is in Spanish, and I speak Spanish, but I'm not necessarily very good at reading it. But I think she said I was an excellent doctor. So, gracias. All right, cool. Let's see. Let's see, what are the types of questions that you should ask your OB when you first meet them? That's a good question. That's kind of a long question, too. It's really, I'll try to run through a few ideas with you here in a second. Am I accepting new patients? Yes, I am at Circle of Life. And obviously, you know what that is because you're on Circle of Life's Facebook page. So, yeah, absolutely. What questions should you ask as a new patient with an OB, as a new pregnant person? It's a good question. And there's like so many things that you could ask. Most of which you can probably summarize in a couple of big picture questions. One of which is, how do you feel about evidence-based medicine? And what the heck does that mean? What it means to me is, if you look at these YouTube videos that I've made, the general concept is I'm trying to use the best available evidence to help my patient to have the best possible outcome. And there are studies for everything nowadays. And the thing about it is, in years past, like say when I first started training, 1997 is when I started residency, a lot of things we did were just, we did them because that's the way we did them. That's how we did it, and that's how we're gonna do it. And that's how we teach the next generation how to do things. And there's a lot of doctors out there who, were trained prior to then, who are still practicing, who are very much that way. They're just kind of set in their ways. This is the way I do it, and I don't care what your fancy study says, I'm not changing. And so I think that, working with someone who is mentally capable of processing research and evidence and being up to date, I think, personally to me, that's one of the most important things, because so much stuff is changing all the time, and so many things we just knew were true 10 years ago turn out to be completely false. And I'll give you a good example. So there was this trial we participated in at McKay called the ARRIVE trial, and it involved about 6,000 women, and they were first-time moms, and they randomized these first-time moms to either being induced at 39 to 40 weeks or waiting until about 41 weeks, unless the baby came sooner, obviously, to be induced at that time. And the reason was that the general consensus was induction of labor increases the risk of C-section. And that's what some people have believed for many years. And it turned out, based on that study, that induction of labor reduced the risk of C-section in the 39 to 40 week group, and the risk was higher in the group that waited. And there may be a whole host of reasons why that is, but that's what the end result was. And that is completely contrary to what most people probably believed. So the concept being, if you don't read the studies, how do you know, right? And so you got to be up to date. And so I think more than anything, that's one of the most important traits in a doctor. Beyond like liking them and feeling like you can make a connection with somebody and get along with them, and that, they take time to answer your questions. I really just think, like, if you just ask that one question, how do you feel about evidence-based medicine? You'll probably learn a lot. Let's see. Haley, do you take patients that are not expecting? Yeah. So yeah, we do. I'm a OB-GYN, so we deliver babies, but I do GYN stuff too, and basically anything kind of women's health is right up my alley. All right. Let's see. I think I'm caught up again. So we'll give another couple minutes, see if you guys have any other questions, and then otherwise we'll probably wrap it up for this week. Let's see. Just talking to your mom about induction, 5 kids, all induced 40 weeks and delivered naturally. There you go. So that it just kind of goes along with the thing that I was just saying. So I'll tell you another one that's interesting, and you would get a lot of feedback from a doctor on, are things like, tell me what you think about normal labor progress. That sounds like such a strange, vague question. But if you're dealing with somebody who is reading the literature, they will tell you right off the bat, oh, there's this great article called Preventing the First Cesarean. And it was published in the Green Journal, which is our journal, the American Journal of OB-GYN, or actually Obstetrics and Gynecology, the Green Journal. And it basically challenged every notion that we ever had about labor progress. We used to, since the 60s, feel like, okay, labor is always like this. It always changes at this rate, and if you're not changing by that amount, you need a C-section. And the general gist of that article, not to belabor the point, but the bottom line was, that ain't how it works. That's kind of what more recent research would indicate. Epidurals have an effect. And data from one dude study in 1960 something or other, Dr. Friedman and the Friedman curve, just does not apply. So if you've got somebody who is staying on top of the literature, they're going to know all about that article, and they're going to be able to quote you all these different little pathways that are outlined in that article that really tremendously influence how we manage labor. It's just everything, and it kind of comes back to C-section rates, because if you follow the much more liberal guidelines now than the old Friedman curve, you got to stay on the curve or it's a C-section, you will get a lot lower C-section rate. So that's another good question to ask your let's see, Samantha, do you feel cervical checks are necessary? No, you don't have to have them. I think that they can be informative. So, excuse me, if, for example, you have a history of fast labor, it might be good to know if you're walking around 5 centimeters, but how often does that happen? Not very. So I think that it's useful just to kind of keep tabs on how things are progressing, but by no means do I feel like, oh, you got to have it, you got to do it. So I think it's a personal thing, and if a patient doesn't want a checker, no big deal. I won't check her. So I wouldn't worry about it. If you're not interested, just skip it. I would only say, like, don't ignore signs of labor. So, like, if you're walking around at home and you're 36, 37 weeks and you have no clue what your cervix is and you're booming out contractions, you might have a baby quicker than you realized. So just keep that in mind. But otherwise, I have no problem with not checking somebody's cervix, particularly just routine exams. Different story, of course, if someone's having signs of labor, then you probably need to be checked. All right, let's see. How often do you prefer pregnant women to visit? Your whole pregnancy felt okay, no problems at all. Do you visit every month? So it probably varies a lot from country to country, but I can tell you that in the U.S., generally speaking, until from say the first visit somewhere in the first trimester till about 28 weeks, visits are typically monthly. And when you get to about 28 weeks, they typically go to every 2 to 3 weeks until the last 4 or 5 weeks when they're weekly. Now that on average is about 13 visits. That's a lot of visits, particularly if you're low risk pregnancy and it's not your first baby and everything's going okay. So I do think there's certainly room for flexibility in there. There are definitely certain landmarks that we got to hit, because the majority of prenatal care is preventative medicine and just kind of monitoring for complications. And if you're not being seen, it's kind of hard to do those things. So, but I think if you hit those basic landmarks, that if you didn't have a visit or two here or there, no big deal. All right, let's see. People say they pushed for hours. Can you reduce this time? Can you just allow more time for baby to come down naturally, or begin with pushes that are making progress? So this is it's a good question. There's a fairly recent article that looked at delayed pushing, or what people call resting and descending, and it's kind of mixed results in that. And I haven't looked at the study in a minute, but I made a video about it, and it's on my YouTube channel in the third. Hey, Ashley, how's it going? In the third trimester / delivery postpartum playlist, I think that's where I put it. So delayed pushing. So if you get to completely dilated and you start pushing right away, that's sort of immediate, or roughly speaking immediate, versus waiting some pre-specified period, an hour or whatever. And what were the differences? And there was a little higher risk of postpartum hemorrhage, I want to say, and a little higher risk of more severe peritoneal lacerations in the group that didn't start pushing right away. But the differences were subtle, and it was nothing that was like earth-shattering. So, I kind of tend to be more of a just start pushing when you're complete, but by no means do I feel like it's set in stone. But that study made me think a little bit that maybe, not waiting to push better, but I have no idea. But look back at that video, and I'll go through the numbers, and you can kind of decide for yourself. Let's see. What have you low-dose aspirin while trying to conceive and when you're pregnant? Good question, and thanks for people asking. Like the video, thank you. What do you use on low-dose aspirin while trying to conceive and when you're pregnant? It's an interesting question. The short answer is it is not beneficial for the majority of people. There are a couple situations where it could be. One is if you have recurrent pregnancy loss and have been diagnosed with antiphospholipid antibody syndrome, which is a mouthful of a diagnosis. But if that's the situation, then you need to be on a low-dose aspirin, and you actually need to be on a blood thinner like heparin or Lovenox. Now, if you have a history of recurrent pregnancy loss, but you have tested negative for antiphospholipid antibody syndrome, then there's no evidence that low-dose aspirin is going to improve outcomes, so I don't recommend it in that situation. Now, there are other situations where low-dose aspirin might be beneficial, one of which is if you have higher risk for preeclampsia. So there are studies that show that you can reduce your risk of preeclampsia if you start a low dose, which is really not 81 milligrams, but more like 110, 120 milligrams at the first trimester. So if you have a history of preeclampsia, if you have past medical history of chronic hypertension, if you have twins, and there's probably chronic renal disease, maybe 2 or 3 others I'm not thinking of off the top of my head. But if you have these risk factors for preeclampsia, then starting a low-dose aspirin, say at around 13 or 14 weeks, reduces the risk of preeclampsia by something like 20%, which is substantial. So I think those are the two situations where low doses of aspirin can be beneficial. Pretty much in no other circumstance is the evidence there that it's going to help. So unfortunately, say for example, like recurrent pregnancy loss, if you don't have antiphospholipid antibody syndrome, I have the hardest time saying that, there's just not a whole lot you can do. Most of them are chromosomal. And those that are not, if there's a small chunk that are this APS, and then those that are not, there may be some that are vitamin D deficient, and there's some evidence for that. So making sure your vitamin D levels are up to snuff, or just taking a vitamin D supplement would probably cover that base. So long-winded way of saying in a couple of specific situations it's a benefit, and then most others it's not. Okay. All right, let's see. I think I'm caught up. Give us another couple minutes and see if any other questions pop up, and then otherwise I think we'll wrap it up. Let's see. Okay, Amber says, what's the infection called that's tested pre-labor? Do you know why here in Australia we don't routinely check for it if only if we request? Interesting. So, okay, so what you're talking about is group B strep. And there's a video on my channel about that, so it is pretty close to the top. If you just search from the top of my videos, just most recent, it's like 4 or 5 down in there somewhere. So what you're talking about is group B strep, and that is completely different than strep throat. That's group A strep. So we're talking about a vaginal bacteria, group B. And there is risk associated with group B strep if it's not treated. So in the US, it is standard of care to routinely screen everyone 35-36 weeks. About 1/3 of all pregnancies, the mom will test positive. If you are group B strep positive and you labor and deliver vaginally and you were not treated with penicillin or other appropriate antibiotics, there is an increased risk for the baby of infection from that group B strep. And most commonly, it's like sepsis, so blood infection, that's bad. Meningitis, that's bad. So it's definitely something that's preventable. That's why it's routine. It's been routine here for 20 years. I'm surprised to hear in Australia they're not doing it routinely. I thought most industrialized nations were doing that. Some places maybe still go of a risk-based approach. So if you have a fever in labor, or if your labor has a prolonged period of time of ruptured membranes, I think it was 18 hours or something like that, then in those situations they would treat it, but not just because you were positive or it's not even a test. So I would do it. And if I was a patient in Australia and they weren't routinely doing it, I would request it. And it's routinely done around 35 or 36 weeks. So just definitely keep that in mind. Watch the video, it's on the channel, that kind of talks about it in a little more detail. Let's see. Is glandular fever dangerous? This is your 2 weeks and your son has it. First question is, what is glandular fever? So it's kind of a vague diagnosis, and I mean, I don't know if they gave you like a specific thing if they said that it was this particular bacteria or this particular viral infection. Because off the top of my head, I'm just gonna jump on this thing called Up to Date, which is a website that I use to stay up to date and see if there's any specific diagnosis associated with that term. But if you know what it was, let me know while I'm looking this up. What's mine? Oh, cold sore virus. Okay. I'm assuming like a herpes infection is what you're talking about. Glandular fever. Yeah, I mean, I can't imagine how, I'm still not sure that we're talking about the same thing. So let me just see if I can log on here. I'm just going to see if there's anything that pops up for that common term. Glandular fever. Let's see what we get. Oh, mono. Yeah, okay. It's mononucleosis. So I've heard that term, but it's been so long that I knew that it had to be something. So it's Epstein-Barr virus is the infection. You know, chances are pretty good. Most adults probably had it when they were kids, and so in theory you should be immune, and probably not a big deal, but not wrong to just try to use good hand hygiene. It's sort of one of those secretions and some degree of respiratory spread, so just trying to not get coughed on or sneezed on, and wash your hands good, and probably be fine. And like I was saying, most people got that when they were kids. like sounds like your kid. So probably you're immune, probably not a big deal. Um, but I would just say kind of standard anti-infection type precaution, probably the best way to go. You'll be fine. All right, let's see. 2 years to conceive after a C-section. No. There is evidence if you look at the interval between deliveries at less than 2 years versus more than 2 years, that in the group of people who delivered, not conceived, but delivered, less than 2 years after their first C-section, you had a little higher risk of uterine rupture in labor. So, and that probably just has to do with, allowing enough time for the uterine scar to heal. But it's not a huge risk. It probably doubles the risk. So if you said to somebody, the risk of uterine rupture from one prior C-section is about 1%, and then your inter-delivery interval was less than 2 years, maybe it doubles it. So it's about 2%. So not the end of the world. I mean, not ideal. But if someone came in pregnant, I wouldn't freak out about it. But really, you're talking about the interval between deliveries and not waiting a full 2 years to get pregnant. Hope that answers your question. Okay. Well, sections and you want one more baby. Is it safe? There's definitely some risk. And there's a video on my channel about this. It's called Risk. Sorry. Hang on. Hush. It's just a person walking their dog. It's okay. Yeah. It's okay. Someone walks a dog by the door in the neighborhood and the dogs freak out. Okay, sorry. So risks of multiple C-sections. This is the question. There's a video on my YouTube channel about it that talks about it in some detail, but to give you the highlights. Number one, that many C-sections, there's a decent chance of scar tissue in there involving bladder, bowel, and there's a higher risk of injury to those organs from just relatively opening and closing your abdomen. So there's that. And that's not typically a huge risk, but it's a risk. And it can cause complications as a result. The next one is there's a higher risk for intraoperative bleeding, and it kind of probably comes back to the scar tissue thing again. Just everything's all scarred down. It's hard to get in there. In that process, you get some bleeding. It occasionally leads to bad things happening, and that's it can be difficult. It can also lead to a difficulty delivering the baby. Kind of same reason, like that whole lower abdomen is just all scarred in. And it's just difficult to get the baby out. So difficult deliveries are more common. And all those things are potentially problematic, but none of them are nearly as scary as the other thing. And the other thing is called Placenta Accreta. And it's a real risk after that many C-sections. So the thing is you can't control where your placenta implants. So if your placenta implants over your C-section scar area, so basically over your cervical area, that's called placenta previa. When you've had 4 prior C-sections, if your placenta implants in that area over your C-section scar, the risk of placenta accreta is something like 70%. And what the heck is that, placenta accreta? That is where the placenta will invade abnormally deeply into that C-section scar, and then you can't get it out. So baby's born, and then if you try to remove that placenta, it won't come out, or you'll get a piece of it out, and then you'll develop massive bleeding. And I've seen it. It is seriously scary. It is potentially life-threateningly bad. And I'm certain people have died from it, no question about it. So that's the one that really, you can't get around it. You can't control where the placenta implants, but you can control how many C-sections you've had. And so that's the one that I really emphasize to people when they're talking about, could I maybe go for one more when they've had three or four C-sections? Well, this placenta accreta thing is a really big deal, and it's not talked about enough. I think people think, oh, things looked fine in there, it should be fine, but you can't control where that placenta implants. And if it implants over that C-section scar area, it is life-threateningly bad. Such a risk that here in Utah, so down at the university in Salt Lake, they have a referral center. So if you have a patient that's suspected of having a placenta accreta, we refer them down. They deliver them at 34 weeks, and they do a hysterectomy. So they don't even touch the placenta. Just take out the baby and then take out the uterus. And even in that situation, you can get into massive bleeding. And there's even potential for that placenta to have invaded through the uterus, say into the bladder. You can have bladder injuries, ureter injuries. It's a huge deal. So that's the one. That's the one that you can't control, and the only way to avoid it is just stop having C-sections, which unfortunately after 4 pretty much means, stop having babies. It's good advice. It's not what people want to hear, but it's the truth. So I just think, I've never told anybody what to do, but I would want to make sure you're aware of it. I think there's a dog and a cat fight going on back there. What's going on? Oh yeah. I can't get to them. They're there. Our dog loves our cat. Our cat loves our dog. Sometimes. Okay, let's see. Jamie said finasteride already, but what hospitals? Yeah, so I deliver at McKay-D and Ogden Regional in Ogden, Utah. Oh, there's a serious fight going on back here. Can you guys see this? Hang on. There it is. For your viewing pleasure. Oh, you can't see it on this one. Dog and a cat are fighting. Sorry, that's not why we're here, but it's entertaining. Okay. All right. People are laughing about that. You have 7 dogs? Holy cow. That's a lot of dogs. We're down to 2. Let's see. All right. Can gestational diabetes happen anytime during pregnancy? Yeah, I mean, it can. And if you're, that's still going there, sorry. We routinely test around 28 weeks or so. But it can happen at any time. Let's see. All right, cool. I think I'm caught up, you guys. So maybe we'll give this another minute or 2 and then probably wrap it up for the day. I can't believe you have 7 dogs. That's a lot of dogs. What kind of dogs are they? All right. Well, I hope you enjoyed the dog and cat fight. Jack Russell, you have 7 Jack Russells? Holy cow. That is a lot of dog energy. Because we have 1 Corgi, and he's like nuclear powered. He's crazy. We love him, but he's nuts. Okay. Well, I'm not seeing any other questions roll in, so I think we'll probably call it good right there. Thanks to everybody. Oh, you used to breed. Wow. Okay. One last question. Here we go. Friend had 6 C-sections. Yeah, I know. There's always somebody who's done it. Doesn't mean it was a good idea. I'm glad they're okay. Casey says, should you be concerned if you can't feel your IUD strings? Let me modify the question slightly and say, could you feel them before? So if you were able to feel your IUD strings in the past and now, for whatever reason, you can't, it's worth just getting it checked. The majority of the time, what's happened is the strings are just kind of sucked up inside the cervix, and so you just can't feel them, but the IUD is fine. The only way you're going to know is to get an ultrasound. So that'd be my advice. Just get it checked out. And assuming the ultrasound is IUD is still in good position, then nothing to worry about, and it's no problem to get it removed when the time comes. All right. Your son is saying bye. Bye to your son in Italy. All right. Well, thanks to everybody. A little short, but can't feel now. Yeah, I'd get an ultrasound, check it out. All right, cool. Okay. Well, thanks everybody for your questions. We'll wrap it up there. A Malamute and a Lab Retriever. That's a lot of dog fur too. We have 1 Golden Retriever, and that's a lot of dog fur. All right, guys. Thanks to everybody for watching. Really appreciate it. Thanks for jumping on. We'll catch you next week, and see you on the internet. Bye.